Parkinsonism is a syndrome characterized by a resting tremor described as pill rolling, bradykinesia, cogwheel rigidity, and postural instability. The most common cause of Parkinsonism is Parkinson's disease, which is a chronic neurodegenerative disease resulting from the idiopathic loss of dopaminergic neurons in the nigrostriatal pathway, which is important for the control of intentional movement. Additionally, while it has traditionally been considered a motor system disorder, Parkinson's is now recognized to be a complex condition with diverse clinical features that include non-motor manifestations such as cognitive dysfunction, mood disturbances, sleep disorders, and autonomic dysfunction. In this sketch, we're going to focus on treating the motor symptoms of Parkinson's specifically. And since we're going to be talking about increasing movement, I want to introduce you to a few friends of mine who are in the business of moving certain goods for a certain price. No questions asked, capiche? In case you can't tell, we picked the wrong day to visit this bank because it looks like we're in the middle of a heist. Just stay calm, no one tries to be a hero, and we'll all just wait for the proper I know it seems like the wrong time to bring this up, but take a look at that door to the open vault. It's kind of geary, right? That's right, the cogwheel design is our recurring sketchy theme for the cogwheel rigidity of Parkinson's. Okay, so dopamine is absent in the nigrostriatum of patients with Parkinson's disease, right? Why not just give them some dopamine? Well, dopamine has problems with crossing the blood-brain barrier, so if you were to administer dopamine to your patient, it would just sit there in the peripheral circulation. Not helpful for Parkinson's. Now, in this sketch, getting past that blood-brain barrier is like getting inside this bank vault. And if you take a look at the interior of the vault, someone has cracked that safe and made their way inside. Levodopa is the immediate metabolic precursor of dopamine. And here's the thing, it does cross the blood-brain barrier. At Sketchy, dopamine is symbolized by a strand of dopamine rope. Levodopa, then, is its immediate precursor and is kind of like coiled rope waiting to be used, coiled around a spool. And we've even included an L-shaped crank handle to remind you of L-dopa specifically. Once L-dopa enters the brain, it's decarboxylated to dopamine. Think of decarboxylating as unfurling that dopamine rope and putting it to use. Dopamine is now able to access D2 receptors in the nigrostriatum and enhance central dopaminergic transmission. Levodopa remains the most effective treatment for the symptoms of Parkinson's disease. Dopa decarboxylase, the enzyme that converts L-dopa to that dopamine your nigrostriatum craves, is not only located in the CNS, though. After levodopa is absorbed from the small intestine, over 97% of it is immediately metabolized extracerebrally, decarboxylated into dopamine that can't cross the blood-brain barrier, and it's stuck in the peripheral circulation. Think of that as this L-dopa spool of rope here that didn't make it inside the vault and is now being decarboxylated, unraveled into that dopamine rope. When L-dopa is allowed to be converted to dopamine in the peripheral circulation rather than the CNS, some pretty significant adverse effects emerge. Nausea and vomiting are common, hence our nauseated hostage here who's really feeling that tight dopamine rope. The vomiting has been attributed to the stimulation of the chemoreceptor trigger zone by dopamine outside of the blood-brain barrier. Fortunately, tolerance to this emetic effect develops in many patients. Peripheral conversion of levodopa to dopamine can also lead to a variety of cardiac arrhythmias, including tachycardia, ventricular extrasystole, and AFib. Postural hypotension is also common, and that's why our next hostage here tied around the chest is getting... No, she's completely out. Yeah, not going to remember a thing. High doses of levodopa can also cause various behavioral changes such as anxiety, agitation, insomnia, confusion, even hallucinations. In this hostage here with the rope tied around his head, looks quite disturbed indeed. These are central effects of dopamine, of course, so presumably large doses of L-dopa lead to lots of L-dopa reaching the brain where it's converted to dopamine and goes crazy inside that CNS. Reducing the dose of L-dopa can be helpful in alleviating these adverse effects. Recall that antipsychotics block central dopamine receptors, so maybe, just maybe, you could throw on an atypical antipsychotic if behavioral side effects persist. Think about it. Alright, those were some of the immediate effects of excess dopaminergic stimulation. Long-term L-dopa administration, though, is characterized by a whole new set of adverse events. For example, fluctuations in the clinical response to levodopa occur with increasing frequency as the disease progresses. In some patients, this is experienced as a wearing off reaction or end of dose effect, in which symptoms of akinesia and dyskinesia start to re-emerge about 4 hours after the dose of levodopa. Think of it like this dopamine rope here getting cranked out by that L-dopa spool. Once the rope is nearing its end, however, it starts to look a little worn off, kind of like the end of dose effect, if you will, when the rope becomes dysfunctional earlier than expected. In other patients, the fluctuations in symptoms are unrelated to the timing of levodopa dose. As this robber inside the vault points to his watch, I want you to think of long-term administration of L-dopa, like they've been inside the vault for too long. The alarm has gone off. Not good for the robbers, of course, but what I want you to focus on is that off and on light flashed by the alarm. This symbolizes the on-off phenomenon that can occur with chronic L-dopa administration. In this phenomenon, off periods of marked akinesia alternate over the course of a few hours with on periods of improved mobility. For example, your patient might tell you that they're getting episodes of sudden, restricted mobility lasting several hours, sometimes freezing altogether. These episodes alternate with symptom-free periods in which he's mobile and feels well. As Parkinson's disease progresses, the therapeutic window for levodopa narrows. As a result, even small changes in serum drug levels can result in motor fluctuations. Too much dopamine and you've got dyskinesia and uncoordinated movements. Not enough dopamine and your patient experiences bradykinesia and rigidity. Unfortunately, over time, the response to levodopa therapy becomes unpredictable, and these fluctuations occur independent of dose administration. So, as he holds up that watch, don't just think of it taking too much time. He's indicating that their window to make an escape is closing, a narrow therapeutic window. While these patients may experience improved mobility during those on periods, sadly, these periods will often be marked by significant dyskinesia. Dyskinesias occur in up to 80% of patients receiving levodopa therapy for more than 10 years. Chorioathetosis of the face and distal extremities is the most common presentation. Kind of like this robber here, the new guy on the team, not quite used to all that dust that accumulates during a raid. This sneezing motion is meant to evoke an image of the involuntary twisting and writhing movements of the face and distal extremities characteristic of dopa dyskinesias. The development of dyskinesia is related to the dose of L-dopa therapy, though there's considerable variation among patients. I want you to recall that the treatment of psychotic patients is all about blocking that CNS dopamine, so guess what? L-dopa and the rest of Parkinson's therapies will cover, which are all geared toward increasing levels of CNS dopamine, they're contraindicated. You may even exacerbate mental disturbance in psychotic patients. Notice that in the vault, a local collector has stored his prized self-portrait from the most psychotic of painters, Van Gogh. Damaged in the raid, it now appears to be crossed out to remind you to avoid the use of levodopa in psychosis. So, if only a tiny percentage of L-dopa reaches the CNS due to its peripheral conversion into dopamine, how do we increase that bioavailability? By blocking peripheral dopa decarboxylase, of course! See that police car outside? Well, it's scaring this robber here who is in the middle of decarboxylating that L-dopa and cranking out that dopamine rope. This police car represents carbidopa, the peripheral dopa decarboxylase inhibitor. You see, carbidopa cannot cross the blood-brain barrier, so it sits parked in the periphery, blocking the peripheral conversion of L-dopa to dopamine. Now, all that L-dopa can head to the brain instead. Notice how the frightened robber tugs on the shirt of the sadistic side effects-inducing robber in the lobby. "Let's get out of here, man!" As they dart into the vault with those L-dopa rope cranks, think of all that L-dopa entering the brain. Not only that, those peripheral dopamine ropes can't torment those hostages anymore. Adding a dopa decarboxylase inhibitor to L-dopa significantly reduces the nausea, vomiting, arrhythmias, and postural hypotension associated with peripheral dopamine activity. Adding carbidopa to levodopa does not decrease symptoms of anxiety and agitation, though, because these are due to the central effects of dopamine. Anxiety and agitation can even be increased because more dopamine is available to the brain. So that last hostage there, the delirious one, he's coming with them. Not only is levodopa metabolized peripherally into dopamine, it's also methylated into the inactive metabolite 3,0-methyldopa by catechol-O-methyltransferase, or COMT. Thus, even with the administration of carbidopa, only 5 to 10% of L-dopa reaches the brain. In the same fashion as COMT, notice here that one of the bank's security guards has seized his opportunity to be the hero and inactivates that L-DOPA spool with his pistol, as he alerts the authorities on the intercom, emphasis on the COM-T. Consequently, another way to increase the bioavailability of levodopa is with the administration of COMT inhibitors such as entacapone and tolcapone. I thought I recognized those guys. Their faces have been plastered all over the tabloids for years. They're members of the notorious Al Capone gang. Yeah, you heard me right, Al Capone. You should be scared. Let the tall, gangly gangster represent tolcapone, while the shorter gangster on the lookout at the entrance guy, every team needs one, represents entacapone. Both of these agents inhibit peripheral COMT as depicted by this inhibited bank clerk unable to make the emergency call on his intercom. Combining levodopa with entacapone helps increase the plasma half-life of levodopa and prolong the therapeutic effect of each dose. Consider adding COMT inhibitors to treat Parkinson's disease patients with motor fluctuations associated with levodopa-carbidopa therapy, including those wearing off periods and on-off phenomena we talked about. COMT inhibitors should only be used in combination with levodopa. They're otherwise ineffective. Unlike entacapone, who remains peripherally at the entrance, the lookout guy, tolcapone has both peripheral and central effects. Tolcapone also blocks COMT in the brain, normally responsible for metabolizing dopamine into 3-methoxytyramine. So it helps to increase the levels of dopamine in the CNS. Notice how this other towering member of Al Capone's gang has relocated centrally into the vault to take care of that last intercom security guard before he can metabolize that rope. Tolcapone can cause increased liver enzymes and has even been associated with deadly acute hepatic failure. And if the sight of this Tommy gun weren't threatening enough, now we've attached a frighteningly hepatic-shaped clip to the tall gangster's gun. You better watch your back, liver enzymes. For this reason, entacapone is generally preferred. Otherwise, the side effects are similar to those experienced with levodopa therapy. Another drug that increases the availability of dopamine in the CNS is selegiline, the monoamine oxidase inhibitor. Yeah, you've seen that ridiculously cute black mouse before at Chateau Tyramine, where we were introduced to all the MAO inhibitors used to treat depression. Recall that monoamine oxidase A, represented by an albino mouse, metabolizes norepinephrine, serotonin, and dopamine. Monoamine oxidase B, represented by the black mouse here, metabolizes dopamine selectively. Quite evident as this black mouse chows down on that dopamine rope. Selegiline, therefore, is aptly represented by this sledgehammer about to smack that dopamine-nibbling mouse, decreasing the breakdown of dopamine in the CNS. As a result, selegiline enhances the anti-Parkinsonism effects of levodopa and, like the COMT inhibitors, can be used as an adjunctive treatment in patients experiencing the wearing off or on-off symptoms. Selegiline only has minor effects on Parkinsonism when given alone. Also, remember that the adverse effects of levodopa we mentioned earlier may be exacerbated by these drugs. More dopamine means more side effects. Check out our video at Chateau Tyramine for more information on the other side effects and indications for the MAO inhibitors. Rather than increasing the availability of dopamine in the CNS, let's try acting directly on the postsynaptic dopamine receptors instead. While the older ergot alkaloids are now rarely used in the treatment of Parkinson's, like bromocriptine, which we encountered in the JAK-STAT and the Beanstalk video for the treatment of acromegaly, there are newer options with fewer side effects to choose from. Ropinirole, for example, which is a D2 receptor agonist, is signified by the big spool of rope in a roll, ropinirole. And notice that it's actually two ropes strung together into an escape ladder. A double rope ladder is our recurring sketchy symbol for activity at D2 dopamine receptors specifically. Now look at this robber performing the grunt work, lifting up that rope in a roll. Let his exposed pecs remind you of the dopamine agonist pramipexole, which preferentially binds the D3 dopamine receptor. Dopamine agonists have an important role as first-line monotherapy for Parkinson's disease, and their use is associated with a lower incidence of the response fluctuations and dyskinesias that occur with long-term levodopa therapy. As a result, dopaminergic therapy is often initiated with a dopamine agonist to delay the need to initiate levodopa. Like COMT inhibitors and MAO inhibitors, dopamine agonists can also be added to levodopa therapy to help control end-of-dose akinesia or the on-off phenomena. As a quick aside, I want to mention that dopamine agonists can also be used to treat restless leg syndrome, or RLS, as represented by this escapee here restlessly moving his legs on the rope ladder as he tries to find his footing. RLS is characterized by the uncomfortable urge to move the legs accompanied by an unpleasant sensation. Symptoms are more common with inactivity during lying down or sitting, and they're relieved with movement including walking and stretching. This uncomfortable feeling can be particularly troublesome at night and cause delayed sleep onset. Treatment with the long-acting dopamine agonists, including ropinirole and pramipexole, is the first-line treatment for RLS. The side effects of the dopamine agonists are similar to the side effect profile of levodopa, including GI distress, hypotension, and cardiac arrhythmias, and even dyskinesias. The psychiatric side effects mentioned previously can actually be more severe with the dopamine agonist compared to levodopa. Of particular concern are various impulse control disorders that may be enhanced by the activation of D2 and D3 receptors in the reward center of the CNS. These include gambling, compulsive shopping, and hypersexuality, or what I like to call the rock and roll lifestyle. Well, this is the 1930s, so the swingin' lifestyle? Anyway, this robber here is flashing a unique identifying tattoo to the public as he makes his getaway, which surely won't help his alibi during the lineup. Just remember, rock and roll ropinirole. Remember too, like levodopa, the dopamine agonists are contraindicated in patients with a history of psychotic illness. And finally, there is one more agent I want to mention that affects dopamine levels in the CNS, amantadine, symbolized here by this priceless statue of a manatee in the vault. Ooh, Swedish green marble? I hope that thing's insured. I know my manatee is. Amantadine was originally designed as an antiviral influenza agent, but it's also known to have dopaminergic activity. Amantadine likely enhances the effect of endogenous dopamine by increasing dopamine synthesis and release while also inhibiting its reuptake. Let these increased levels of dopamine be signified by this extra store of dopamine rope being broken open by the falling manatee statue. Amantadine therapy can alleviate some of the motor symptoms of Parkinson's disease, although it's less efficacious than levodopa and its effects may be short-lived. Alright, the last drugs to cover that are used in the treatment of Parkinsonism are centrally acting antimuscarinic drugs, benztropine and trihexyphenidyl. These will be symbolized by the gangster's getaway car waiting for them outside. Take a close look at that hood ornament. You've seen it before. Yeah, it's that classic Benz logo, as well as the 3 hexagons for trihexyphenidyl. Remember, in Parkinson's disease, there's a loss of dopaminergic neurons in the substantia nigra and correspondingly unbalanced high levels of acetylcholine. These central muscarinic antagonists can help restore the normal balance of cholinergic and dopaminergic influences on the basal ganglia. Notice how the getaway car waiting outside keeps its motor running and shakes with a tremor. It turns out that these centrally acting antimuscarinic agents can improve the tremor and rigidity of Parkinsonism but have no effect on the bradykinesia. Restoring the cholinergic dopaminergic balance is especially useful in the treatment of extrapyramidal symptoms caused by dopamine blocking drugs. Check out the Atropine in Wonderland video for more info on benztropine and trihexyphenidyl use for this indication and their major side effects. Okay, we're running out of time here, so let's sum up this sketch. The whole goal of treating Parkinson's is getting dopamine back in the brain. You can use a direct dopamine agonist such as ropinirole or pramipexole. You can decrease the breakdown of central dopamine with selegiline, or even amantadine can be used to increase the availability of dopamine in the CNS. If you're going to start your patient on L-Dopa, remember that less than 3% of it makes it past the blood-brain barrier and into that vault. Carbidopa increases the bioavailability of L-Dopa by blocking dopa decarboxylase in the periphery, hence the rope unfurling robbers are scared into the vault by the police car parked outside. By preventing peripheral conversion of L-Dopa to that dopamine rope, it can prevent many of the symptoms caused by excess dopamine in the periphery, including GI distress, arrhythmias, and hypotension. That CNS disturbed guy though, he's going with them. In fact, carbidopa can make CNS side effects even worse. The other way to increase the bioavailability of L-Dopa is to block its metabolism by COMT, the job of entacapone and tolcapone. Tolcapone works both in the periphery and CNS. Long-term treatment with L-Dopa therapy can lead to fluctuating motor symptoms seen either as a wearing-off effect or as the on-off phenomenon. And as the leader points to his wristwatch, that therapeutic window of levodopa is only getting smaller and smaller. And lastly, if tremor is the most prominent feature of Parkinson's, consider an antimuscarinic agent such as benztropine or trihexyphenidyl represented by the trembling getaway car waiting outside.
Hi. Front door's open. I'll get it. I got it, Jeff. I'm going to go to the left side.